probably go through that. So I'll just read out the names, and if people could say if they're present.
That would be helpful. Thank you.
Councillor Armstrong. No. Bowman.
Present.
Sesford.
Present.
Dungworth.
Present.
Hutchinson.
Present.
Nisbet.
Present.
Patterson.
Present.
Rickaby.
Present.
Simpson.
Present.
Okay.
Great. Thanks for that. In which case, I'll start the agenda now. Apologies for absence, Leslie.
I've not been given any apologies.
Okay, thank you. Item 2 are the minutes of the last meeting, which we need to confirm are a true record and to be signed. Are you happy with those, colleagues? I see no dissent. I see fingers up. So yes, the minutes have been approved. Item disclosure of members' interests that haven't already been declared. Are there any? I can see nothing on the screen, so we'll move on. Forward plan, that's item A, appendix A.
Sorry, Leslie. Forward plan is just attached for information. It's a list of things that are going to Cabinet on the dates and any proposed scrutiny dates. And there's nothing on there for this committee, so it's just for information.
I have to note on top of my papers, so we note that. Okay, thank you. Right, so then the next item is the Health and Wellbeing Board minutes. Again, this is to accept. And a lot of it's going to be covered in the rest of the meeting anyway. So are we happy to accept those minutes? Yep. Okay, thank you. So then we come on to the first substantive, which is the update on the COVID-19 outbreak. Obviously, things have moved on, but I'm sure in Lizzie's capable hands, we will be told what we need to know and what we need to pass on to other people. So Liz, I can't see you, but I'm sure you're there somewhere. Yes, you are.
Thank you very much, Chair. So the report that you've got was written probably about 3 weeks ago now, and clearly this continues to be a really fast-moving situation. So I'm just going to provide you with a sort of brief overview of how the sort of infection has changed across Northumberland over the last couple of weeks. So just to put this all into perspective and how rapidly this is changing, in the 2 weeks up to the 18th of August, we had 27 cases in that 14-day period. 2 weeks later, we had 65 cases. So that's in the 2 weeks up to the 2nd of September. And in the last 2 weeks up to the 18th of September, we've had 266 cases. So that's a 10-fold increase in cases over the last sort of 5 or 6 weeks. And that really reflects what's going on in other areas of the Northeast. The latest data that I've got, which goes up to the 18th of September, suggests that our rates are now 40 per 100,000. So that's the number of cases over a 7-day period, 40 per 100,000. That's gone up significantly. Well, almost doubled actually in the last sort of week or 10 days. And of course, there is, still quite a bit of geographical variation with, quite a few of the cases being concentrated in the southeast of the county, which is what we would expect really, because that's where, a significant proportion of the population live. And we know that transmission is lower in rural areas. In terms of how transmission is changing, the report talks about the fact that we're seeing, at the time of writing, we were seeing a lot of cases in younger people. So the average age had dropped from 50 at the end of June to sort of mid-late 20s, sort of 4 or 5 weeks later. But what we're seeing now is that the average age is now increasing. And that is of concern to us because obviously it is people in older age groups who are more likely to have long-term conditions, and particularly care home residents who are most vulnerable and nationally, we are seeing an increase in admissions for COVID-19 again, which is obviously what we're trying to avoid. The other thing that we're seeing is that when you look at the differences in testing between Pillar 2, which is all of the testing which is done in the community through these lighthouse labs, and Pillar 1, which is all the NHS laboratory testing, we're seeing an increase in the number of cases coming through from NHS laboratories, which I think again reflects people getting COVID-19 in the community, being admitted to hospital, but also just a general increase in community transmission. And what we have now is widespread community transmission. I'm just going to focus on a few areas really. The first is around testing. You'll be aware that there are significant issues in relation to testing across the country, and certainly that's reflected in Northumberland. We're working really hard to put in place additional testing sites in the southeast. One of those is up and running. I think the other one is being built as we speak. So there's one in Blythe and one in Ashington, and I think the Ashington site did go live over the weekend. So hopefully that will improve access to testing for local residents, because I'm very aware that people have been required to access tests, at quite a distance from where they're living, which is obviously unacceptable. We're seeing a lot more activity in schools. Obviously, as schools have gone back, we're seeing an increasing number of cases in children, and they're becoming apparent in school. They're becoming apparent in schools. So the current information I've got is that we've got 22 schools across the county with positive cases. But we also collect information on children who are reported to us as having suspected COVID-19 symptoms rather than confirmed cases. And when we look at that data, about 6% of suspected cases have gone on to have a positive test. That may be an underestimate, because obviously some parents have been unable or unwilling to have their child tested. So schools have been quite an issue for us over the last couple of weeks. All of that work that Public Health England would normally have picked up around schools has been transferred to the local authority to manage, because Public Health England is struggling with capacity. So we've been picking up all of that work over the last few weeks, and I think it is just starting to settle down a little bit. The other real area of focus for us continues to be around care homes, and we've had about 10 care home outbreaks since the 10th of July. Only 4 of those remain active at the moment, and 3 of them had occurred just in the past week. But we are also getting through, because through the whole care home testing process, we're also getting through reports of staff and residents who are testing positive, who don't have symptoms, and we're managing that through a really good wraparound support team that we've got in place to support care homes. And I think over the next few months, care homes will need to continue to be a real focus for us. As you're aware, last week we went into or became an area of intervention. So we're now one of 44 local authorities, which is on the government's watch list as an area of intervention. That's happened quite rapidly, and we had to put quite a lot of time and effort into a fairly rapid interpretation of the regulations, which came out literally a few hours before midnight on Friday, which was the point at which they were introduced. And I think it's fair to say that we're still working through the regulations to get some consensus on what their meaning is, because some of the detail is missing. So obviously we're working across the 7 local authorities to make sure that we're taking a consistent approach. I think that's probably all I was intending to say in terms of an update on COVID-19. I mean, as I said right at the beginning, this is changing very rapidly, and I think it will be interesting to see over the next 2 or 3 weeks whether we are able to try and contain the increase in levels of infection. I mean, across the 7 local authorities, Durham, County Durham and Northumberland still have the lowest rates. But as I said at the beginning also, our rates are escalating rapidly. So, and it will be a couple of weeks before we know whether any of the restrictions which are put in place will have had any impact on trying to contain rates at the current level. Very happy to take any questions should anybody have any.
I would like to ask one, Leslie, if I may.
Yes.
We've opened the new testing site, Liz, but I believe that part of the problem with getting tested is not just the site, but the actual behind the, actually conducting the tests because of some shortages. Is opening up the Ashenden site actually going to eliminate that, or is it just going to continue the same?
I think we have to wait and see, but I understood that they did do 70 tests on the first afternoon that they were open. One would like to hope that those tests were actually done on local residents, but actually we need to look at the data to make sure that is the case. But I think, appreciating that there is a national prioritization of tests, and that's why some of the testing has been really difficult to access in the northeast because it's being diverted elsewhere. But I'm hopeful that actually having some local testing sites in the southeast of the county will increase access for communities in those particular areas, and in fact communities across Northumberland.
Have we got any information about when those 70 tests which were taken have had their results, or is it too early yet? Because that's obviously the problem, isn't it? How long it takes between getting the test and getting the result?
Yes, I think there is also an issue around the turnaround times for tests, and that's particularly the case for care homes. I think the turnaround times have suffered as a result of the increased pressure on the testing system. And I don't know what the turnaround times are at the moment, but obviously the sooner you get the result back, the sooner you know whether you have to continue your isolation period or whether you can return to normal living as long as you feel well enough.
Right.
Thank you.
Thank you. I've got Councillor Hutchinson indicated, then Councillor Nisbet, and then Councillor Dungworth. Ian?
Thank you. I've got concerns about the rules and the clarity of the new rules. Things seem as if they haven't changed really in the area. Well, I'm in the Blythe area now, or living in the Blythe area, and things haven't changed. People are still going out and about. Pubs close at 10 o'clock. Yeah, I've heard people walking past the house, when I've been in bed at 11:30 and heard people walking past the house. Now, if pubs have closed, they can only be in one place, and that was another friend's place. So I'm concerned that these rules are just being flaunted anyway, and we're not going to be any better off. I agree these rules should be put in and take place, but the clarity of the rules is not very clear to the public. You can go to work, you can go to a pub, but you can't go and see your friends in their back garden and social distance at the same time. And it just seems a bit of a mess, actually. It's a shame because this is going to be one of our last chances, presumably, to try and alleviate this problem. It's really, really bad, and it could get worse. And unless the public help in a major way, it's not going to get any better. It's going to get a lot worse. So they're my concerns, really.
And I completely agree with you. I think the the communications element and how effectively we get those messages across are really important. And I think the fact that we've had to put further restrictions in place demonstrates that actually, we haven't been able to maintain those behaviours that will prevent transmission. And so we're now sort of trying to force people to sort of adopt some of the behaviours that we're trying to get them to comply with. I agree. It is really confusing unless you're buried in it, which I am. But I think we really appreciate, and I don't know whether Anne is on the call, but we've had a conversation today about the importance of communications and getting those messages across in a way which resonates with all communities across our county. It is a really tricky one.
May I come back, Leslie, please?
Yes.
Is there anything happening regarding anyone who is flaunting? Are there any whistleblowing measures? Are the police doing anything? Do we do something and whistleblow, which is rather tricky when you've got neighbours flaunting the thing? I would hate to be pointed at as being the one that pointed the finger and said they are breaking the law. So is there anything that the police are doing or we can do to assist in the rules being adhered to?
So, I mean, I think, clearly this is a collective effort. We need to be doing this as communities and as a population across the county. And we've all, as we keep on saying, everybody has got a part to play. And I think as the elected leaders in your area, I think your role is really important in promoting the behaviours and the measures that we've put in place and encouraging people to comply with those. I think going to the police is a really difficult one because there is a danger that you'll just increase sort of tension within your particular community. But certainly there is a mechanism in place to through dialing 101 to ask the police for support. So they've got one process for people who should have come back from holiday and been self-isolating. They've got a mechanism in place to just check with border control whether those individuals should have been self-isolating or not. But certainly when I've contacted Northumbria Police about issues in other areas, they've been happy for individuals to phone 101 and highlight concerns. And I think the police will need to take a bigger role in ensuring that these restrictions are complied with.
Happy, Ian? Okay.
Not happy, but thank you.
No, as I say, happy is the wrong terminology, but acceptance.
I would like to think we'll get some better determination of the rules to have more clarity. I.e., you can go into a pub, but you can't go into somebody's back garden to socialise with them. That kind of thing. Or you can go to work with them, but you can't socialise. Thank you.
Thanks, Ian. Right, Councillor Nisbet, Kath.
Hi, thanks. It's follows. I've had a constituent on the phone this morning quite irate about the testing centre in Blythe being put in the car park opposite the Civic Centre. Apparently they had no consultation, but yet I was told that there was consultation going around the residents. But here the marquee is right opposite her house, and she's got a young baby and she's hearing a generator going on all the time. And also she's quite concerned about people going in and out that testing centre, which is right in front of her door. Have you dealt with that? Because I believe she was sending you an email.
Yeah, so thank you for that. So I have had an email from somebody who's raised concerns about the testing centre in Blythe. and one of the executive directors is going to respond to that. I mean, I think, you know, from our perspective, it was a real priority to get something in place in Blythe, and there weren't actually many areas where we could put a testing centre, which had the, you know, the space that we needed. Last week, I mean, we were originally told that the sort of timeline was going to be the beginning of October, but actually, with a few local representations, that was really accelerated last week. And I think, to be fair, that the communications that we would have liked to have done, we were then unable to do because of the fact that it was done in such a short period of time. But I think, you know, it is being done for the benefit of the people of Blythe and the people in the southeast, so that they, you know, so that they can access the testing that they need in a manner which is easier than it is at the moment. And I apologise if it's going to, you know, cause some inconvenience to some residents in Blythe.
You happy? Okay, Kath?
Well, I'm not, but I mean, don't get me wrong. I think it's much needed to have the testing centre in Blythe. It's just the fact of where it is, that's all. Because I've been and had a look, and it is right opposite our house. It's sort of you've got the back lane, you've got about 5 metre distance, but it's still there for all to see what's going on, that, you know. And I think there is still some concerns around there. So, but as long as we can get back to it and have some kind of solution, I'll be pleased with that.
Point noted. Councillor Dunn with Susan.
Yeah, thank you. I mean, I think the reality is we need testing centres close to where people live, and that's been one of the issues, that they've been placed a long way away and you've got to have a car to get to them. And I think part of what's recognised in the southeast of Northumberland is the low car ownership in some areas. So we're going to run into this problem, and I think it's about individual conversations with people, probably. But I think that you've done very well, Liz and the team, to get these 2 testing centres open, or nearly open in the second case, in such a short time. Because I would still maintain that South East Northumberland, if it was a separate authority, as it nearly was with Blythe and Wansbeck, we would be up there with the South Shields numbers. It's only because we've got such a large geographical area with rural areas that it keeps our numbers relatively low. But in the urban areas, we're facing the same problems as our neighbours, actually. I think there is an issue with the testing labs behind the scenes, and, you know, there is no point in us doing it. It sounds like I'm now saying, after arguing for testing centres, that there's no point in it. I don't mean that, but actually the back office stuff has to catch up, or else people have no faith in that system. So we need to keep lobbying for that to happen. But I really wanted to talk a little bit around the messaging. And I think we have got a problem, because nationally we've got a confused message, and we've had confused messaging throughout this crisis. And I think what we need to do is get messages across to the 99.9% of our population who do what they're asked to do. If they understand what they're asked to do, there's always going to be those few people who don't. I think we need to reinforce the messaging. I know you've already done it, Liz, but maybe a bit more specifically around who goes for tests, to release some of the pressure on testing. And it wasn't in our area, but I'm quite sure it's happening here. I was horrified this week on the television to see a care worker take her elderly disabled parents to stand in a queue to get a COVID test when they had symptoms. The messaging used to be, if you've got symptoms and you don't need a test to get back to work, stay at home and only contact the services if your condition worsens to such an extent that you need more medical care. So we seem to be having people with symptoms standing alongside other people with symptoms, going out and about in order to get testing, when actually they don't need a test, because it doesn't matter whether they've got it or not. They should be isolated if they have those symptoms. Do you understand what I'm saying? And I think that was quite clear at the beginning of the epidemic, because we didn't have the testing. So it was basically stay at home until you're better and don't mix with people. So if we could do, I know we've said don't get it if you're not unwell, but I think we also need to think about, you know, if people are unwell, is it necessary for them to go out and get a test, or should they just stay at home? And I think the other thing is tying in with what Ian was saying, and it is around what people can do and what they shouldn't do. And I think we need to focus with our communication on some of those shouldn't things. Yes, pubs are open. Yes, all the shops are open. Yes, the soft play is open. But really, in order to try and stop this community transmission, the best way to do that is for people not to do those things for a while. Or else you've got this madness of mixed messaging, which I think is what we've got at the moment. You know, our message is we want the health service to be able to continue. We want the care service to be able to continue safely. And that means the people who work in those services interacting as little as possible with anybody else, and education. So to do all those things, the rest of us have to stop doing things and as well. And it's something quite simple like that. But we need to be blunt with people. This is the last chance.
I think that's a point well made, Susan. And the one thing I'm going to, before I think Ian wanted to come back in, but just one question. What is the movement, if any, on informal childcare situations? I mean, I fall into the bracket of, you know, I've opted out because obviously I can't interact with another family. They're not in my bubble, etc., etc. I think that's another message that really has to be sent out there, that although it puts people in a very, very difficult position, again, we've just got to stop this interaction and communication and passing on the disease. But I just wondered, I know there's a lot of people out there obviously raising the issue. I just wondered, Liz, if there was anything that's been said about it.
Yeah, so I mean, this is a national issue, and when we were having conversations with the Department of Health about the sort of restrictions that we would be seeking, you know, we were very specific about asking for an exemption for informal childcare. But unfortunately, that wasn't reflected in the regulations when they came out. You know, all I can tell you is that you know, the issue is being escalated through multiple routes to the Department of Health, and I understand that some sort of meeting is going to be held in the next week or two to look at this, because it is a, you know, it is a national issue, not just a local issue.
Okay, thank you. Ian, did you want to come back?
Yes, please. It was just a comment Susan made. I agree, appreciate, and loads of things she says, but there was one comment that she said about travelling to testing centres, and if people didn't have cars, etc., they would have to travel by bus. I think, in my opinion, that's the last thing anybody should do, is travel by bus to a testing centre. I think you should be travelling at worst by taxi, but preferably by family or friends by car. I think public transport, you should, if you think you've got it, stay at home. Keep off public transport though, don't go by bus. Thank you.
I wasn't saying to go by bus. What I was saying was we needed testing centres where people can walk to, because the reality is, if you don't have a car, then you will be forced into either, because I wouldn't go in a taxi. I don't know when I'll next go in a taxi, to be honest. I think they're probably more unsafe than buses. But so I wasn't saying to use public transport. I was saying that's why we need them near houses, and why there's going to be a bit of a conflict sometimes.
My apologies, I took it up wrong.
Right. Thank you. Trevor, Councillor Sesford.
Yeah, hello, Liz. I've got a couple of, well, one question, 1 point I want to make. I've had people contact me about what to do when the suspect, one was a daughter, had sent home from school with possible COVID symptoms, and I told them how to get online and check to see if they get a test and things like that. Now, one of the issues they came back to me was that one of the officers a home test to be sent out, and their interpretation, or what they've told me, is that there's a problem with home tests and they haven't got any left, or not enough to go around. Mine might have just been on that particular day, I know that, but I've also heard that from 3 or 4 other people that there's actually a problem with the home test. So that's one question I want to know. But another thing I want to comment is that the people going for tests, and that sometimes there's been having been sent a long way away because there's nowhere close for them to go. But some of that's caused because these centres that may be closer are fully booked up. And one of the reasons for that may be, or certainly is in some cases, a lot of people who are just going without any symptoms. I heard the other day, now I don't have that first-hand, this is second-hand information, that one particular person is well reported to have done 12 tests over the last few months, almost on a weekly basis, just to check whether they've got it or not. And it looks, by the way, you've heard that story as well. So what I would like to ask is yes, I agree with nearly what everybody said about the need to have targeted communications, but one area we're not probably doing is also to target this area, telling people that, you know, only go if you've got symptoms and not just clog the system up. And therefore, the back system are actually checking the tests as well.
Yeah, so I think those are really good points, and that was probably me who started the story about the individual who had 12 tests. So it was a particular individual who'd had a test every week for about 3 months, and obviously that is diverting our testing capacity from people who are symptomatic, and it's the people who are symptomatic that obviously we want to test, and it is a significant number of tests which are being undertaken on people who aren't symptomatic, and that's when you take out the whole care home testing process, which obviously is routinely done on people who aren't symptomatic. So that is something that we're trying to, the message that we're trying to promote is, please don't get tested if you haven't got symptoms. And if you haven't seen that, then clearly we need to keep promoting it a bit more vigorously. Going back to your first point about constraints on home tests, I think the constraints on testing are across the board. So it's very likely that somebody will go online to try and get a test and won't even be able to access a test to be sent to their home address. But I understand that throughout the day, slots are released across the county, so it is a question of sort of just keep trying to see whether a testing slot does become available closer to home. I think the other problem is that some people are booking a test, and it might be a long way away, and then actually when they go online later on, they find that they can get a test closer to home, but actually you can't cancel the first test. So there are all sorts of problems with it, but the root of it comes down to the fact that that there just is pressure on capacity because of the increased demand on testing. But we have had authority to go ahead with a northeast testing and contract tracing hub. So that funding was and support for the initiative was announced on the 11th of September, and I gather that there's an aspiration for that to be up and running at the beginning of December, and that will be run. That will be a sort of testing lab for the northeast, run under the auspices of the NHS rather than a commercial body, and that's a venture that's being led by sort of Newcastle Council and the Newcastle Hospitals Trust.
Thank you.
Okay, just before I wrap this one up, Kath McAvoy-Carr has indicated that they are doing an audit of available childcare places in case anybody wants to access formal childcare in the interim period. Kath, did you want to say anything else about that?
No, well, yes, I will do. Sorry, I'm really sorry. My camera is not working today, so it's not that I'm being ignorant and hiding behind the lack of camera. It's just to say that we are aware that that won't be appropriate for a number of people, but in case anybody does want to access childcare, we are looking at what's available and liaising with our childcare providers to see what options there might be in the very short term.
Okay, thank you. Well, Susan?
Yeah, I just wondered if there was any capacity to support people with that, because obviously there's a cost to childcare, and quite a significant cost as well. So, you know, people use family members because they can't afford childcare. So I just wondered if, as a local authority, we were giving any thought to that.
Not at this stage, but obviously it's not far from our minds in relation to that, and that's why I said it will be for everybody the opportunity to access formal childcare, because I know that the cost is prohibitive for quite a lot of people, but it is something that we're doing in order just to try and alleviate it for some people if we can.
Yeah, sorry, I need to come back again at that, because that still puts people, the most vulnerable people, the lowest paid people, at risk of either not going to work and not getting paid or losing their jobs, or going to work and using family members. So I think we need to be thinking of those groups of people sooner rather than later as authority, please.
Okay, Councillor Bowman. Les, did you want to add to this?
Yeah, thank you very much for the childcare provisions. I had somebody contacted me at the weekend who works in the National Health Service, and they're not getting any childcare cover for the weekends, and so obviously she can't go into work and provide the care that's needed. Can we look at that as part of a priority when we start looking at childcare provisions?
Okay, well, thank you all for your comments. I mean, obviously, as we said, this is a moving feast, and, you know, we don't know from one day to the next what's going to happen. I'm grateful for all the comments made, and I'm sure Liz will be taking those and Kath into consideration. I don't think there's anything, I haven't got anybody else indicating to speak. So for Leslie Bennett's benefit, I think the recommendations are that we are invited to comment on the progress being made, and we've done that, and comment on any perceived gaps or areas of concern. So I think as a committee we've fulfilled our recommendations. Okay, I don't see any dissent, so can we move on to item 7, which again is Liz, Appendix D, and that's on the creative health the public health annual report.
So thank you very much. Hopefully something a little bit more cheerful than coronavirus. So as you'll be aware, directors of public health are required to publish an annual report every year based on an element of sort of health which we think is relevant to our population. And this year the report was about arts and health, and really the report was intended to build on the really solid foundations that we've got, and to explore how we can embed the arts more firmly within clinical care and across the prevention agenda. What the report intends or attempts to do is to really highlight the impact that the arts can have on health in its very widest sense, and it takes a bit of a life course approach. So it looks at the impact that the arts can have on prenatal and postnatal mental health, looks at how the arts can support children to improve their sort of social bonding with parents, looks at how it can improve their readiness for school, explores how the arts can help to manage long-term physical and mental health conditions better. And certainly we know from our own Northumberland Recovery Partnership, which is our drug and alcohol service, that actually the arts can have a really significant impact on individuals who may be the furthest away from employment. It can really help to increase their confidence, improve their self-esteem, to a point where they're confident enough to write a CV and apply for a job. We find that the arts are quite effective at reducing the risk of falls, so it can improve strength and balance in people at risk of falls. And we also know that theatre is a really effective way of educating people about, particularly young people, about positive health promoting behaviours, helps them to confront issues around stigma, and provides coping mechanisms for a range of mental health problems. We can also use the arts to improve clinical skills in healthcare professionals. And, you know, with one of the bigger medical schools on our doorstep, we've got a really good opportunity to look at how we can promote that in our region. I think we've got a lot of the building blocks in place to really drive this forward within Northumberland. We've got a university which is really keen to work with us. We've got a regional integrated care system which has an arts and mental health work stream as one of its priority programs. And I think, you know, potentially we're pushing at an open door to become, you know, a bit of a beacon nationally in terms of bringing together the arts and health. So there are 4 recommendations at the end of the report. I think potentially the biggest impact is the recommendation to develop a Northeast creative health hub. And certainly before March, we were having some really active discussions with Newcastle University about how we might take that forward. Unfortunately, coronavirus has reduced our capacity to really take this forward, but it's certainly not something that we're going to forget, and we will be picking it up as soon as we're able. So that's a really brief sort of summary of the report. Very, very happy to take any questions should anybody have any.
Liz, thanks very much for that. I must admit, I'm going to take chairman's privilege and make a statement first, because I have long been waiting for such a report. I really enjoyed reading it, and certainly in my area for years. Don't get me wrong, I'm an ardent sports supporter, played a lot of sport myself, but equally I'm very much into arts and crafts, and have long thought we should give people the opportunity that aren't sporty to do something else to enhance their creativity and well-being. So really this for me is the cherry on the cake, and I've been waiting a long time. But I know Susan would like to make a comment. Susan Dungworth.
Yeah, thanks, Chair. I'm going to pretty much repeat what I said at the Health and Wellbeing Board. First of all, thank you for this report. I'm always really proud of Northumberland and its annual public health reports, because they're a bit different, because we look outside the box. And, you know, a lot of the things that have become important in the last year around community assets and the value of communities were brought to the forelight in our council through public health. So thank you for that. I've always been an advocate of the arts in terms of people's both physical and mental health and well-being. So it makes absolute sense to do this. A couple of points. One is maybe a 0.5 on there. And I know it's talked about in the blurb a bit more, but you know, our arts sector is really struggling. And I'm not even going to say post-COVID, because we're not post-COVID. A lot of it comes through the community and voluntary sector, and a lot of places where people will access it is through that. So we actually need to have some kind of support recovery plan for those organisations, or they're not going to be there to help us deliver on this. And I know it's about money, but we're talking about money, investing money to save money as well. And my final point is, and I think you're talking about it a bit differently there than you were when it came to health and wellbeing. I have no problem with us kicking this off and leading by example, but I still do not think Northumberland County Council is in a position to lead a project like this with other authorities at this time. And I think we've got many other things we need to sort out and be delivering on, not least COVID at the moment, rather than trying to engage local authorities who will similarly be looking inwards, I think, at the moment. So I would like to put that bit of it on the back burner until we're in much more normal times, I would say.
Before Liz comes in, Claire, I've got you as the next speaker after Liz. And Jeff. So Liz, Claire, Jeff. Okay. Thank you.
Yeah, so thank you for that. Yeah, and I completely agree with you. I think you know, our priority, particularly now that coronavirus cases are escalating again, our priority is very much on COVID-19 and protecting the health of our population. But I won't allow this to, go on the back burner for eternity. I will pick it up when the time is right and make sure that we take it forward, because, I too am a passionate advocate of the arts. I've seen for myself the impact that it's had on people's well-being. So I think it is important that we do pick it up and do something with it in due course.
Thank you. Claire?
Thanks, Councillor Rickaby. Fully support this work. I think it's really great work. It's great to see that the Trust Breakthrough Bright Northumbria is represented in this document too. Just a few things. There are pockets of work happening across the county and it's really fantastic to see. Liz, you want to hook in with this, but we've just agreed some funding with to do some artwork with care homes during such difficult times, to just try and engage them in some art activity for the Trust, and with the view that they'll be displayed across our Trust. So you might want to look to see how you engage in some of that virtual work that we're doing too. But really happy to support this and really happy to get involved.
You're on mute, Leslie.
Pressed it twice. Jeff, your turn.
Okay, just going back to what Susan was saying, totally agree with you, Susan, about how these organisations are going to recover from them. But I just want to make sure that we understand there has been a lot of support for some of these institutions. It's never enough, but I'm involved with 2 village halls, 3 charities and Woodhorn, and all of them have had substantial grants to help them over the crisis so far. So it's not as if nothing's happening. I think the problem will be how long this goes on for, and in particular effect for those people who are relying on footfall of people coming into their organisations to spend the money to help to create the business continuing. I think there's an issue coming up that we need to keep our eye on and try and help as much as we can.
Okay. I don't have anybody else indicating that they wish to speak. Oh, sorry, Councillor Bowman.
Yeah, thank you very much for this report. It's welcomed. Can I just add, I've read many reports about loneliness, and I've seen it in the communities as well. Single people and even couples can be living a life that's lonely. And if this report will open up their lives, as it were, if they were to get involved with the arts and take on an interest outside of their 4 walls, as it were. So yes, it's welcome. We all know that loneliness causes very many health problems, not just mental health, but physical as well. And if we enhance people's lives through the arts, well, that's good. Thank you very much. I really appreciate it. Thank you.
Councillor Patterson, Wendy.
Thank you, Leslie. Liz, I just wanted to say, like Leslie, I really enjoyed reading that report. I just found it quite inspirational. And if I can do anything in the future to assist with this, I'd be very happy to.
Thank you very much. That's much appreciated.
Okay, again, thanks, Liz. I would endorse what Wendy said. It is something that I'm really passionate about. So if there's any way I can help, please feel free to get in contact. On that note, we have noted the contents of the report, and we've certainly made comments which I know will be taken on board. So thanks again for the report, Liz. We move on to item 8, which is the Northumberland End of Life Strategy. And I believe Andy Stewart and Alan Bell. I see you, Andy. Off you go. Thank you.
Yes, thank you, Chair. Alan Bell. Well, I think actually Alan's going to introduce the paper, and I'm going to answer any sort of more clinical type questions that may arise. So I'll let Alan kick off if that's okay.
Okay. Floor's yours, Alan.
Thank you, Chair. So yes, I'll present my screen.
Following on from the engagement on the Walton unit.
I can't hear anything. Is anybody else struggling with the sound?
Oh, can you hear me now?
Yeah.
Thank you.
Thank you. So yes, so following on from the engagement on the Walton unit, the recommendation from OSC was to review current end-of-life strategy and update it as required. So it was to ensure that strategy reflected the health and social care system, including the voluntary and community groups. So there's a need to further engage with local population and including those hard to reach groups. And so I think there was a will for the strategy to encompass care and hospital out in the community and within people's homes. So back in January of this year, we formed a strategic task group with key stakeholders from the health and social care sector, and that included a patient representative and members of OSC. So we met once in January and then once again in March of this year. And we started to form some local ambitions and look at a roadmap to develop the strategy further in Northumberland. So as part of that process, we started to review national policy and look at how we ensured integrated services around end-of-life care. And unfortunately, at the meeting in March, we had planned a meeting in April, but because of COVID pandemic, that unfortunately was delayed. So our approach was sort of threefold. Was one, to look at what the data was telling us, to work with our colleagues from public health, primary and secondary care information teams to look at actually how can we use data to inform the strategy development, and also use that data to actually look at what does success look like, how do you measure outcomes of a successful strategy, and then moving on to that, mapping current pathway and highlight any gaps within the current pathway. As part of that process as well, to engage with our communities and then use that information to form a strategy. So the initial findings from the task and finish group. So we looked at the National Council for End of Life Ambitions, which has developed quite a lengthy and comprehensive overview of services, and look at that to map services out and identify the gaps. A lot of that is we focused on it, how we engage with our communities and understanding their views and acting upon them. And we started to think about the social responsibilities around our communities and our providers, and how we start to talk about end of life and end of life pathways. So we start to look at considering how we looked at urban and rural areas, and also considered deprivation as part of that, of the data process. And also one of the key things that came up was the importance of, if you died in hospital, whether that would ensure that was dying in a private room. So current progress. So in terms of, from a data point of view, worked with colleagues from Northumbria Healthcare and Public Health, as I've said, and also primary care data, to look at developing a bit of an interactive dashboard, and it's using a software called Tableau. So it was allow you to drill down and look at that data and look at various different data sources for end of life care. So that data included things like cause of death, the demographics of the population, place of death, graphically representing that on a ward level and mapping that out and doing a comparison between different years, and looking at things like mortality rates and deprivation as part of that process. So I've just got a couple of slides now which just screenshots what that dashboard looks like. So I won't necessarily spend too much time on this, but so certainly our data experts and Northumbria Healthcare have developed this dashboard with Tableau. And as you can see from that slide, it maps it to ward level, gives an indication of where people in Northumberland died, so whether that was in hospital, a care home, or in their own homes, or in a hospice, what age they were, and then also comparing that on a year-by-year basis. So the next slide is just more detailed information about actually if the patient died in hospital, what conditions they died from. So ICD-10 codes, so looking at whether that was, say, for example, a respiratory or a cardiovascular disease, or potentially cancer. So as I say, this information is going to be an interactive dashboard which you'd be able to drill down on to further information on. So the next slide is talking about deprivation, and so mapping the different wards across Northumberland and looking at how the least deprived and the most deprived and where that impacts. So looking and being able to drill down on deprivation and end of life. So that's the data. And then one of the things I've talked about was that we looked at the 6 ambitions from the National Council for End of Life. And so you might not be able to see that, but basically they've mapped end of life ambitions into 6 categories. So the first one is making sure that each person is seen as an individual at that time in end of life, making sure everyone gets fair and equal access to treatment and care end of life, ensuring that that's a comfortable and maximise the comfort and well-being at end of life, making sure we coordinate between providers. Number 5 is around making sure all of our staff and providers have got the right skills and expertise to deal and discuss end of life in a compassionate and confident way. And 6, this final one, was around the community and the community's effort and response in supporting that end of life area. So we started to look at mapping end of life service on that. So the next slide is really looking at, for each of those end of life ambitions, we've developed a set of questions along support with Andy to actually look at for primary care services, secondary care services, and those in the community, actually understanding how are we doing, how we're performing on those, and looking at what are we doing well, and also where the things where we could do better, and identify any gaps through that process. So the next slide is about engagement. And so as part of the engagement process at the first and second meeting, we started to look at different engagement reports which had already been produced from in the Northeast and nationally, and looking at allowing that to help us to say, what do people want, what staff should do as part of the end of life process, what organisations need to do, and what communities can do to support that process. And as part of that, we start to look at principles for how we involve our communities, and thinking about how we do that and who the different communities are we need to engage with. And just at the sort of March meeting, we started to talk about a different approach and what we call a social contract, which I'll just go on to explain. So social contract is really talking about and agreeing a set of principles for what we expect from our community and what we expect from providers. And this is an example from Wigan Council, which isn't necessarily to do with end of life, but it's spelling out what is our part, what would we expect potentially our community to do around discussions on end of life, and also what our providers potentially would have principles to set. So as part of that process, there has been a small amount of engagement which has taken place on social contacts in general through our comms and engagement experts, and that information is displayed there. So we've asked around social contracts, what are people's thoughts across Northumberland on them, and starting to collect social contracts and general feedback. So I won't spend too much time on that slide, but then the next slide we start to talk about actually an end of life social contract, what would that look like, and there's some interesting feedback. So for example, that first box there, can a social contract survive disruptive times? Does it not require stability and assurance of norms? And it also requires trust, and that fairness will be tantamount. So the inequality between health and social care, especially in a crisis, undermines this notion for end of life care. So I think that's an interesting comment, and I think we at the start of in March we start to think about actually what would a social contract look like for end of life care, and how could we develop that. So generally the feedback on that was quite supportive around a social contract on the end of life. So the next slide talks about good death leaflet, and I think again this is about actually what does a good death look like, and looking at the research around the North East for that. So I think that's an interesting comment around. On the whole, I think it's a very good, positive document. However, what worries me is a push for people to choose to die at home. If they do, they will still do towards the end of life. That will be supported if their family can cope. And I think that comment starts to bring out some of the national end of life ambitions around actually treating each person as an individual and actually reflecting on what their needs and wants are in end of life. And that could be they might prefer to die in hospital or die at home or in a hospice potentially. So next slide is just again talking about the principles of a good death, and quite a lot of the principles of a good death have got some positive feedback. So I think I won't spend too much time on that slide, but certainly we can cover that in more detail if you would like. And then just as a conclusion, so our next task and finish group, so obviously it was paused due to COVID. We were hoping to do that virtually later on this week as a follow-up meeting. I'm aware that there's a meeting clash, so I know that some of the people at that meeting might not be able to attend, so we're going to hold a follow-up meeting for those who can't attend. We're going to look at completing the data dashboard and actually presenting some of that information back to the group that our data experts have developed, and looking at the engagement process and completing that engagement with residents across Northumberland, which is obviously more challenging because it's done virtually, but we're also looking at developing that social contract in more detail. And also I think one of the important points to think about is how we consider the impact of COVID potentially has changed the views on death and the dying, which we need to think about, and also look to finalise that strategy by the end of the new financial year. Thank you. That's the end of the presentation. I will stop sharing my screen now.
Thanks, Alan, for that. Obviously, I'm going to throw it over to the floor, and I think Susan, you've indicated. Susan Dunworth.
Yeah, thank you. Thanks, Leslie. I'm actually in this group. I don't know that people would necessarily know it. I think we've only managed 3 meetings at the most before the COVID restrictions came in, and I think I only managed to attend 1 of those meetings. So I found it really frustrating that things had to stop. And I am concerned that a meeting's still going ahead on the 23rd when obviously no councillors can be involved in that meeting. Because I do think it's important that we're part of that discussion, as the local authority provide a lot of what helps make a good death, I would like to think. So, and I don't know, I just feel a bit like we want to up the gear a bit. I just feel like, so this report, I didn't feel any ownership at all of. So we've sort of lost that connection with it, I think, most members. But it is such a difficult subject at the best of times. I think at the moment, it is really hard to talk about end-of-life care and a good death and do that in isolation from what people are living and dying through at the moment. And that isn't going away anytime soon, as far as I can see. So actually, we urgently, I think, need to be thinking about how we can make a death during COVID as good as possible for everybody concerned. And I know that's really hard, and I know there's national restrictions and things, but you know, for me, a huge part of it is about people dying in hospital. And if they're dying in hospital in intensive care, you can't necessarily do anything about that. But if they just die in hospital because they're in hospital and nobody can visit and nobody can go in, then there is maybe something we can do about that. And I know some hospices have taken a much more holistic approach, and that's because of, you know, the size and the resources. So I suppose I would always go back to, we desperately need more properly state-funded hospice provision in this country, actually. And my final thing is just a plea to our officers, really. A presentation like this is useless in black and white. So when we're sending out presentations, I know we're saving money, I know we're trying to save the planet in terms of the paper we use, but actually you need colour in this kind of presentation. So could we please have them in colour? Because then looking at them on these screens, they're too small to read anyway. So you need that hard copy presentation. So that's just a plea there. I don't mean to sound negative, because I'm not, it's such an important issue for me, this, and I really want to be involved in it, but I really also feel so frustrated about what the current situation is doing to patients who are dying, and to their families as well, and just how hard that damage that's being caused at the moment is going to take to repair. And that I just see us going back into the situation we were before, with hospitals closed down, care homes closed down, everything closed down, people cut off from their families, without us taking that breath to think, how is there any way we can make this a bit better than what it is?
Thanks. Points well made, and I agree with you about the presentation. It seemed to make a little bit more sense when we saw it in colour on the screen. Derry, you had your hand raised.
Yes, thank you very much. I think some of what I'm going to say is going to reiterate what Councillor Dungworth has just said. We're really pleased as Healthwatch to be part of this group, and I think it started off talking about the principles, and I think what's happened is we've been catapulted into a situation where actually it's the practicalities which are now the most important. And I think whether the group actually needs to think about its remit because of that, because I think we can do some of the underlying work and the principles that we set out to do, but I think any help that we can give now in balancing the need of a pandemic situation and for families and individuals who are going through this, not just in hospitals but care homes as well, where people may have not seen their relatives for 6 months onwards, where restrictions are all in place. And I just think that there's a need now to look at the balance between the principles and the practicalities, and helping develop thoughts around that.
Thanks, Derry. Has anybody else wish to add anything to the debate? No. In that case, I would say I've got the idea that this obviously has to come back, because terminology may not be correct, but we're scratching the surface, and we've had the rug pulled from under our feet with the pandemic. So whilst I think a good start has been made, I think I would like to suggest that we bring it back and have a further update as and when there is something more that we can, sort of get our teeth into. And I think Susan's points are very well made. And I see Andy's got his hand up.
Yeah, no, thank you. And all those points are really well made, actually. And I would agree that it was a real shame that we sort of put a lot of this stuff on hold from the pandemic, because I actually think now there's never been a greater need for a palliative care strategy. And I think you could see that from various aspects. I think so one of the points that was was well made there was about frail elderly patients dying alone in care homes, and I think that's been a real tragedy as part of this pandemic, and that's something that is going to be and we are addressing urgently. I mean, I've just come off a meeting to how we can sort of improve families to be with their loved ones who are sort of palliative care patients in the last weeks of their life, for example, to improve access. So, because that holistic care is so important. Alan makes reference to the social contract about some of the commitments that we will make, but also the sort of commitments that we want the community and the public to make as well. And I think people are much more aware of their own mortality at the moment, I think, as well, actually. And I think people talking more about death, and I think that will allow us to have some much more open conversations and develop this strategy as well. So I do think this is an opportune time to develop it, and I think we just really need to invigorate it. And this Wednesday is sort of kick-starting that. We, as you rightly say, we need to make sure council members are part of that, because you're the voices of the community as well as the voluntary sector. So I take all your points on board, and I agree with all of them. I don't know if there's anything more you want to add to that, Alan.
I think yes. So Andy, I think certainly we need to have a follow-up meeting with all of the councillors, and I think just one of the things I would say is that maybe potentially, because it's virtual, actually it might be slightly easier for us to make sure everyone's involved in that process. And I know sort of earlier on in the year we were struggling to get people's availability actually physically in the room at the same time, so actually the virtual setting might actually speed that up, and that certainly we want to make sure that momentum continues in the coming months.
Susan?
Yeah, thank you for letting me come back, Leslie. I think you're right. I think one of the benefits of virtual is it is easier to get people together for shorter chunks of time, actually, than travelling. I just wanted to share something, and I try not to do this, but share something from a personal point of view to maybe help understand this. So, as I said at the beginning, both of my parents have suddenly, well, my mum not so suddenly, but my dad suddenly a massive health failure. He's been in and out of hospital. He's currently in hospital. We can't visit him. His health is failing. The only contact we have is if he manages to phone on his mobile, which he's really inept at doing, or I chase somebody down at the hospital. There's no automatic contact with the hospital and us as relatives. We at home have got my mum, who's got Alzheimer's and cannot move, so has physical and mental health needs. And between us, myself who lives in Northumberland and my brother who lives in Redcar near my parents, have been trying to care for them for the past 4 months now, but the situation's getting worse and worse. I am aware that decisions that we make about my mum might then be influenced by what happens with COVID. So on my level, in terms of best care for her, it would probably be in respite care with some stability, same staff. But I'm aware if we make that decision with her, that the chances are they're going to lock down and we won't see her and she could die in there. So those are the kind of things that people are grappling with now. And that's why, and likewise, my dad in hospital. Likewise, so that's why we absolutely need to be just thinking about how this is impacting. So your people, including myself and my brother, are not necessarily making the best decisions for mum because we're thinking we don't want her go away and not be able to see her. So yeah, I just wanted to get the strength over of how we've got to sort some solution that keeps people safe but doesn't cut them off at the end of their lives from their family. We have to find a way that is possible somehow. And certainly we have to improve the communications between family members and the care. Well, I have to say it's mainly the medical services that just, you know, if you were going in to visit a patient, you would chat to the nurses, you would have a feeling what was going on. We're just absolutely lost here in the system. Thank you, and thank you for letting me do that.
No, Susan, I think that's very important because often when you hear of a personal story, it can put it into perspective even more. And I think you demonstrate quite adequately that we do need to take this forward. It is unfortunate that the pandemic has sort of stopped the progress. And I think, Chris, Angus, I think we need to put this on the work programme for a future date, future meeting, when there's a bit more meat on the bone that you can bring to us, please. Okay. Right. So we're accepting that report with the codicil of it coming back. So we go on to item 9, which is the Complaints Annual Report, Adult Social Care. It's Appendix F, and I've forgotten who's presenting this one.
Hi, James Hillary.
Hi, sorry, James.
Right. I tend not to come to the committee apart from once a year. Hello again to some faces I recognise from last year. If I just, as I said, just talk through the report and then questions or anything else that people want to raise, then that'll be absolutely fine. And I'll also perhaps just stick mainly to the adult complaints because I suppose that's our focus today.
Yeah, thank you.
So in terms of the report, it's in two parts, and it describes the, I suppose, the statutory complaints that we get for adult social care and for children's social care. It also refers in the adult section to complaints that we get that relate to continuing healthcare, CHC funded care, due to the arrangements that we have with the Northumberland Clinical Commission Group. In terms of the adult social complaints that we've received over 1920, in terms of the report itself on page 4, as you can see, there is an upward trend that we have experienced, a quite consistent one over the past 2 or 3 years. And just for comparison, I've added in, as far as I've been able to get, some data from 3 other local authorities, Cumbria, Durham and Lancashire, just to give an idea about how we compare, although I wouldn't necessarily take that as too important, but certainly it gives an indication about what other local authorities have in relation to numbers, and similarly in relation to proportions. I think complaints in Northumberland, generally speaking, are comparatively low compared to the work that's done within adult social care and CHC services. I think the other thing to bear in mind is, in terms of outcomes, I've done a little bit of a few tables over pages 5 and 6 just to give an idea about the kinds of subject matter that people complain about and whether or not complaints are upheld. I think in terms of the bulk of complaints, again, social work care management is the, I suppose, a key area, and that's not unexpected due to the volume of work that they do comparative to a number of other areas. And similarly, as I said, on page 7, for example, we've got a sort of an outline of the kind of subject matter that people might complain, and broadly speaking, how important that is. And I think you'll have read the report and you'll have picked up that issues around finance and funding are, I think, a key issue for many people in Northumberland, and certainly it's one of the drivers, I believe, that is there for people when they complain, because they are being, not everybody, but most people are being asked to contribute an amount towards the cost of their care, which is a national policy, it's a local policy. But I think people are becoming more willing, I think, to challenge services, and certainly challenge services where the issue of money, if not central issue, is certainly an issue that sits within the overall complaint. I've got a couple of tables on pages 8 onwards for CHC complaints, which are much smaller in number, just to give an idea about the areas that people are complaining about and the general numbers. I think the central part of the report is around learning, and that starts on page 10 for adult social care and CHC, and I've included a table that gives some general responses to the kinds of issues that are fairly typical that we get through from a complaints point of view. And I've also put in a number of thumbnail portraits in section 2, just to give an idea about the kinds of things that people have complained about and the kinds of things that officers have done to try and resolve the issues as far as they're able. And I'll just skip through those, and I've done a few for CHC as well, which were on page 14 to 15. The third section is on the Ombudsman, the local government Ombudsman particularly. We haven't had any Parliamentary and Health Service Ombudsman decisions this year, and they would look at CHC funded care packages. In terms of The decisions, again, I've put a little bit of comparative data with the same local authorities as before, just to give an indication about how we fare compared to other those other areas. And I would say in general terms, over 1920, when the Ombudsman has chosen to look at a complaint, they have, I think, the conclusion I would draw is that by and large, we've generally been able to sort things out locally. Obviously not to the complainant's satisfaction because they've gone to the Ombudsman, but in general terms, we haven't necessarily had too much of the Ombudsman's come back and gone, oh yes, but you need to do this as well. So that's fairly encouraging in itself. I've mentioned a few things in the fourth section about inquiries that the team gets, that many of which are, if you like, bubbling complaints, but they're not actually complaints. They're just issues where people feel that they like some kind of answer, but they don't particularly want to make it a sort of a formal statutory complaint. That's not everybody, but certainly a fair number of people, I think, we would capture within the inquiry section. I've added something about compliments. Our numbers are somewhat down this past year because unfortunately Q4 from January, February, March, I think has got lost off in COVID when that occurred. And certainly with the contracts team, we're going to chase that back up and see whether we can get the data from providers for the certainly for that Q4, and hopefully the first couple of quarters in 20 to 21. And I think in terms of advocacy, I've touched on advocacy because people, if they wish, we would endeavour to sort of source advocacy, but it's not a requirement for the social care complaints. And I think lastly, I'd probably just skip over section 7 if anybody wants any comments on that. But section 8 is just a brief summary of, I suppose, our method, the way in which we would look at complaints itself. And as I said at the start, part 2 is about children, children's social care, and it largely reflects the adult services as well, although they haven't seen the same sort of increase in complaints that we've seen in children's over the past 12 months. Obviously, the children's social care judges on the different stages, and similarly the Ombudsman as well as giving a little bit of data about lessons learned. So I think that's probably a quick whistle-stop tour of the annual report, but if anybody has a number of questions, which I'm fairly sure somebody will, happy to take those.
Thanks, James. Susan, you had your hand up?
Yeah, thank you, Leslie. I'm concerned at the upward trend in complaints. Now, I think the previous year, and if not the previous year before that as well, some of the reasoning that was given for that was about an improved system whereby it was easier, simpler for people to complain. And the old adage of, complaints are not necessarily a bad thing because then you can do something about it. But we seem to be booking trends with other local authorities as well. We're going in the opposite direction, or going faster in the opposite direction. And whilst I accept people are more likely to complain or feel they have a right to complain if they are paying for it, and that worries me a little bit because those people who are not paying for it should equally feel empowered to complain, and I don't think they necessarily do. So I understand that, but again, that isn't new anymore. That is what we've been living with for a lot of years now. So I just want to know if we've been, what are we doing to find out why the complaints are rising? I've had a brief look through. There are issues around communication, which again, I'm quite sure have been an issue for the past 3 years at least, about how good communication is between ourselves, the people who use our services and relatives as well. So, you know, at some point we have to stop that upward trend, I would suggest.
No, I mean that's definitely correct that we had upward trend, and I think the finance one is certainly a key issue over the past 12 months when the council's charging policy changed. I think that a number of people were affected more than others. In terms of the opposite direction, I think, you know, historically we've always had a fairly high tolerance around complaints, and if we've been able to resolve things informally and quickly for people, we haven't necessarily logged that as a complaint because the regulations allow us. I think over 1920 we have seen, I think, sort of slight lowering of our tolerance around complaints because of the kind of the nature of complaints that have been brought forward, particularly with that underlying issue around money. So we've always perhaps wanted to try and understand that better. I'm not sure that we're continuing to see an uptrend. And I think if you look at the other local authorities' numbers, they start at a fairly higher level than ours. So I think perhaps we might be meeting in the middle, but I do agree that the underlying point that you're making, that we've got an upward trend and we need to see what we can do about it. I think what we do about that is that we have good links with, from a complaints point of view, we have good links with the social work and care management side of the business, and we do share our findings with them, and we do look to try and embed learning where it's applicable across either an individual team or service area. So I'm hopeful that the trend that we've seen over the past 2 or 3 years of increasing complaints will level off to a sort of a more typical year. And I'm wondering whether the sort of the 40 to 50 mark will become a more typical for us. I'm not sure that we will increase to the levels of, say, Lancashire, which perhaps has a much lower tolerance around logging complaints than we do. In terms of the issues you make around about people who get who don't have to contribute towards their charges, I think we do get a number of those who do complain. That it's difficult to pull out the figures, but I think certainly looking through the individual kind of individual complaints that we've had, they're not all about money, but certainly money, I think, is certainly an increasing driver. I think people's confidence as well to address professionals that has perhaps changed for me over, say, the past decade. But prior to that, people as a group, not necessarily individuals, but as a group, were perhaps quite happy with what they had and had a sort of a mustn't grumble attitude. I think now perhaps there's an increasing sort of understanding that it's right and proper to challenge services if you're not happy with what they're telling you or what they're doing, either for you personally, and as in the case of many of our complaints, they're made by family members on behalf of either an older relative or a vulnerable adult who perhaps is less able to voice their concerns themselves.
Can I just come back a second on that? Because whilst the complaints, reading through some of these examples, the complaints are, one of them, for instance, was a family member complaining about being asked to pay for care that was obviously substandard, unacceptable. But the complaint wasn't about the care. The complaint was about the fact they were being charged for it. So what I'm not seeing, because underneath that, there is a lack of care, that I wonder if it hadn't been somebody who was paying for the service, whether that would even have been in as a complaint. That, for me, that's the most fundamental thing. And that's why I suppose the issue of making sure we make people feel very comfortable in raising concerns about the standard of care that they or their family members are receiving is really, really important.
I absolutely agree with that, and I think following your comments there, I do want to take that back to senior level within adult social care, and we can work out a way of just trying to reinforce through to officers as well, and I think perhaps care providers as well, that the quality of care, if people are unsure about the quality of care, that they need to raise it. Because we would always encourage people to raise it with their service provider or with their care manager in the first instance. That's something that I think we've always tried to do, but there's, I think, to reinforce that and to continue to have that as a message, I think will be a very valuable one. And thank you very much for your comments on that.
Right, thank you. Derry, you had your hand up.
Yes, thank you. I think within the body of the report, you talk at one stage, and it goes to the point you've just been making about those who are paying for their care. But I think you do make reference to people who are self-funding. And again, I just wonder if this is maybe this is a group of people who we hear from those less often, because the primary relationship that they see is obviously with the provider, and not with yourselves, but actually they may have concerns about all of the things we've just been talking about, but may not know and may not be aware that there are ways to complain. And I think again it's how I think again you mentioned this in the report, that the providers are encouraged to share the information and the intelligence they get about the complaints that are raised with them. And I just think that is a really, really important cohort that needs to be heard and built in if we're to get a full picture of the quality of care within the county.
Yeah, I think just in terms of the comments made about self-funding, self-funding as in people who pay the whole cost of their care that the local authority arranges.
Yeah. Or just arranging it for themselves.
Yes, because there's a difference there. The private, because certainly the people who arrange their care privately wouldn't necessarily have a relationship with the local authority.
Exactly, so you wouldn't know about it.
No, each care provider, in terms of or at least the care providers that are contracted to the council, have a responsibility to well, I suppose all care providers need a complaints process, and they need to advertise that to people. And I think the ones that are contracted to local authority, if someone's self-funding, then they would have an allocated care manager. They would have the same kind of relationship with the local authority or the same relationship with someone who was contributing a smaller amount or not contributing anything towards the cost of their care. So I think we do hear, I suppose, from self-funding people. The key bit, I think, is the people who arrange their care privately.
Exactly, that's the group I'm talking about.
Yeah, those people should be able to make complaints directly to their care provider, and then from their care provider they can go to the local government ombudsman. The bit for us is what we do ask is when people make complaints about private care, we do ask the contracted providers to report on those to us, so we get an indication about how many complaints are being made from private service users. So we do have some, I suppose, intelligence or data on that from providers. And I do each quarter when I get, say each quarter, recently hasn't been the case, but each time when I review all that information from each individual care provider, there are occasions when I will go back to the contracts and commissioning team and flag stuff with them if I'm a bit concerned either about an individual complaint or about some of the numbers that might be coming through. So we do have a way of trying to get a bigger picture. I'm not saying it's perfect, but it's
no, and I think I feel reassured about that, because obviously those are the things that that we would want to hear. But I think again it goes to the point that the picture that you've presented to us then isn't the whole picture, because there are then this other sets of information as well. That there are these other complaints that are being made as well, but which aren't reflected in your figures because they don't have to be.
No. It's I suppose the stat, the requirement is around what local authority gets rather than everything else. So that's a fair point.
Thank you.
Okay, does anybody else wish to make any comments? I can't see any other hands up. So I'll bring this to a conclusion. I thank James for the report, and I think the last points that have been made are very, very important, because certainly we need to be sure that everybody out there is being treated equitably and getting the service that they want. Can you just Kath, would you like to come in on this point?
Apologies, because I've just had a grass cutter outside my window as well. I can't believe today. But anyway, so I didn't want to interrupt when James was speaking, but it's just really that, whilst we accept that complaints are increasing, we always see every complaint as an opportunity to learn from, to learn lessons and determine how we might improve things going forward in the future. And we have a system in place for ensuring that those lessons are fed out to case managers, social workers, teams, anybody who that might involve, in order to try and improve the practice, or to look at how we can improve practice going forward.
That's great. On that note, I think we'll call a halt. We are asked to receive the report and identify any additional areas, which I think we have indeed done. It was a good report, and I know that the paragraph 7 gave a very good overall focus on how things have gone, but as ever, you can't always get it right all of the time. And I think that the points that have been made, if we could address them in the future, then it might give us a complete overview of exactly what's going on. And Kath, I think you're quite right. It is one of the points of the report that I enjoyed was the fact that hopefully, and I don't mean that unkindly, that we are going to learn from any experience, whether it is positive or negative. Okay, we're down to item 10, which is the work programme, which we have as ever to indicate what's coming up. And I believe with Chris that generally speaking, we say if there's anything that you wish to add on to the to be scrutinised, please do so. And of course, I will flag up again the end of life coming back at a future date.
Yeah, so the work programmes is there. If anybody's got anything they want to add, just reach out to me or the chair, and we'll discuss it. The next meeting's on the 6th of October. It is quite a tight turnaround, but that's because this one was delayed by a couple of weeks. We'll have CNTW's quality accounts coming at the next meeting, and then Newcastle's the meeting after. I'm trying to pin down a date for the ambulance service. For NIAS to come and present theirs. That'll probably be November, maybe December. The end of life strategy is scheduled to be a sort of recurring item, so I am aware it will be definitely coming back. We just brought this one to this meeting today just to give you a brief update on where they're at, but they are scheduled to come back. But as always, if anybody's got anything they want to add, they just need to let me or the chair know.
Great. On that note, Chris has already mentioned that the next meeting is the 6th of October, back to a Tuesday at 1 o'clock. I have no urgent business, so can I thank you all for attending this afternoon. Susan, I hope everything goes well for you, and can you all please stay safe, and I'll see you again on the 6th. Take care.